Okay, Donna, are we live?
We are now live.
All right. I mean, I know it says live on the screen, but that doesn't always actually mean you're live. So welcome people out there in TV land. We are the Wyoming Legislature's House Labor, Health, and Social Services Committee. We are meeting on Wednesday, February 24th to consider House Bill 38. And committee, as we posted, I'm not expecting in particular to hear public comment because we have heard a lot of public comment, but I offered to people they could be available if we have questions. You know, we've heard a lot of public comment, and probably we don't need to repeat the same thing, so we don't want to hear repetition of that. But as we presumably work the bill, we can hear. If we, you know, we always come up with questions. So people will be available for us to ask questions. Let me just give kind of a reminder. It's been I feel like I've seen this bill like 5 times, and probably I have, along with Representative Hallinan and Representative Stivar. But just a high level reminder of this bill. This bill was assigned to a subcommittee of Labor and Appropriations by Management Council. The request was to develop some prioritization for the state's block grant to community mental health programming in light of the budget challenges, and also just in general under the thought that when the legislature purchases something, in essence, we should identify what we're purchasing. So if you look on page 1, the bottom of the page was a committee amendment, and I'll have some discussion about that later, to put a sunset date in. Kind of unfortunately, from my point of view, the sunset date as drafted right in there repeals the entire community mental health funding program. Pages 2 and 3, we are in the Title 25, which is the statute section for involuntary commitment. And that was just to add in some definition changes, calling places behavioral health centers rather than mental health centers. And then you'll see on page 4, you can see a lot of red paragraphs inserted in there. And that was to work in the sunset component into Title 25. Page 5, is Title 35, which is duties of the Department of Health. A lot of the components there are just phrases, slightly different usage in phrases. You'll see on page 6, picking up the definitions, much of that was just a wording change. The real meat begins in midway through page 7. As we set up the definitions, and again, this was the work done by the subcommittee and then brought through the Labor Committee as a preference rather than through appropriations. So we are defining what the categories are. On line 13, adults with acute mental illness. So those are people who had been under an involuntary hospitalization or were released from that recently, to make sure that those people got the follow-up that they would need. Bottom of page 7, we have adults with severe mental illness, which was an amendment that we did during the interim committee to make sure that they were able to provide care to people with a severe mental illness and not have to wait until they were involuntarily committed to give them help. Representative Stivar.
Are we going to take roll call?
I'm sorry. Thank you, Representative Stivar. Donna, no, let's see. Bonnie's doing roll call. Look how slack we are. Bonnie, I will interrupt my speech.
Okay, Madam
Please call the roll.
Representatives Clifford.
Here.
Connolly. Representative Connolly.
Here.
Flittner.
Here.
Hallinan.
Here.
Ottman.
Here.
Martinez.
Here.
Stivar.
Present.
Worf.
Here.
Madam Chairman.
Here.
9 present, Madam Chairman.
Oh, good. Thank you, Representative Stivar. Okay, picking back up on page 8, families at high risk. So this is our reflection of our desire to make sure that children with challenging psychiatric needs could receive services here. We have, as you saw, a couple of different categories: the child, their family in conjunction with the child. Over on page 9, we have indigent general access clients. So these are people who do not have private or public health insurance. In other words, keeping in mind that the clinics can certainly, we're not stopping them from seeing Medicaid or Medicare patients or people with insurance, but those people obviously their services can be billed for. It doesn't have to come out of the block grant. So these would be people, probably adults who, seeing as we're not a Medicaid expansion stage, these would be basically very low income adults, between 19 and 64, that sort of thing, up to 150% of the federal poverty level. Page 10, indigent clients with high needs. So in other words, indigent people and having one of the mental illnesses. Then we have the whole category and again, keeping in mind, these are just definitions, non-state level justice involved. So a lot of this is a follow-on, as you'll recall, to our justice reform work that we've done over the last few years. And really having seen the last few years, and we had a bill on that out of Labor Committee last year, how we really needed to up our game as far as following up on people coming out of the correction system or who have been impacted by the correction system with mental health and substance use problems. That's a really significant need. So we had non-state level justice involved. In other words, people who've been in municipal court or that kind of thing, or federal, let's say they could be. Okay, and page 11, we just say these are the priority populations. This isn't the priority list. This is just the list of, in other words, this doesn't identify 1 through whatever as at the priority level. It just names the categories that we just defined. Then, excuse me, page 12, we just talk about how the counties may also contract with these organizations. That's optional to them. And in a way, you can say, well, the reason is we're just changing the language there. The counties or school districts can always do whatever they want with private agencies or these groups. We're just changing the language. That was just why that's in there. Let's see. Page 15, again, really kind of clean up language on the sliding scale, which is existing situation. Page 16 then is really getting into the actual prioritization. Line 15, we have the tiers. So tier 1, the justice involved categories, the high risk families, and the adults with acute or severe mental illness. And then we go into the tier 2 and tier 3. Hopefully all those tiers will be covered, and they will also have the ability to serve other people as they have been. We're not stopping them from seeing other people and billing or getting other funding. Page 17, we are authorizing the department to provide essential subsidy payments. In other words, in a rural area, if a center only had, let's just say, 5 criminal justice involved people, they might need to do other things. And you might need to have basically like we do for rural schools, give them kind of an extra boost because of high fixed costs when you have a low population. So that's what that is in there. 18, we just clarify that they can certainly use other funds. They're a private organization. We're not telling them that they can't do anything. We're just directing what we do with the state block grant. And I think the rest is mainly just insertion of the language, nothing particularly different there. And picking up on page 22, section 4, I think this is really key. We want to make sure that this is all done right. So the department needs to consult with the providers regarding a potential reform and redesign, to identify the eligibility requirements within the priority populations, what the subsidy payments would be. In other words, we haven't finalized everything now. I mean, more work will need to be done with input from the providers on how to set that up. Page 23, some sort of pay for performance that rewards providers for administering case management, which is really key to a lot of the people. Prevention, we've got some here, the list on the bottom of page 23, things that we want to have involved in there. Prevention of hospitalization, prevention of reincarceration. Top of page 24, employment where possible, housing. Okay, and then down on page 24, line 16, a requirement for a report back from the Department of Health on how things are going along. We may want to consider amending that date to perhaps a little bit later in the year, with the delay in our labor committee meetings due to COVID. Things are not, they won't have had as long a time to really work on this. If we want to put it off, say to, October 31st or something like that, that will be an optional thing. So that's just a reminder of the bill and what we're trying to do there. Again, I just identify the prioritization for the contracts that the department writes with these providers. So, Donna, let's see, wait a second, I put up by participants. Okay, so I see we have in the hangout room, Andy Somerville is there, Bruce Birkland is there. So Andy Somerville from WAMSAC. I forget, I know I've seen Mr. Birkland before, but I can't remember his organization. Dan Shannon from Department of Corrections, Hollis Hackman from the psychologists, Lindsay Simino also from the counseling group, Lindsay Schilling from DFS, Representative Larson, who was the House chairman of the subcommittee, Cheryl Foland, who is a counseling provider, and Stefan Johansson from the Department of Health. So I think what we might do, just out of courtesy, we'll ask Representative Larson and the other agency people, Stefan Johansson, Lindsay Schilling, and Dan Shannon. Why don't you let them in, Donna? But I think we're mainly aiming at the opportunity for people to ask questions, unless they have a few brief remarks.
Madam Chairman,
Representative Flitner.
just a couple of questions. I noticed there was a language change throughout the bill from substance abuse to substance use disorders. And I noticed there were a couple places where it was not changed. And I just wondered if that was intentional or if we just needed to make sure that it conforms throughout the bill.
Good catch. I didn't see that. Let's ask Representative Larson when we see his picture. I suspect that it's, but why should I hypothesize? Representative Larson, did you hear that question? And you're muted still.
I did, Madam Chairman of Committee. Good morning. I guess I just need to know where they're at. That would help me, Representative Flitner.
Yeah. Where did you see him?
Do you want me to let you know, Madam Chairman, do you want me to note that right now or
No, go ahead. Go ahead and note it now.
Okay, there were two that jumped out at me, Madam Chairman. Page 16, line 5.
What was the page again, Representative Flitner?
Page 16, line 5.
So let me just be clear, Representative Flitner. So and I I didn't look at that. So it says substance abuse disorder, and we're changing to substance use. I see what you're saying.
Right.
Okay, and what was the other one?
Page 21, line 12. And that is, Madam Chairman, I don't believe that is new language. That is,
Right. And that one might actually be correct, because we're not talking about the disorder, but actually an assessment of abuse. But Representative Larson, do you have any thoughts on those two that we noticed?
I would think, Madam Chairman and Representative Flittner, the one on page 16 certainly would want to be addressed. And I'm just uncertain on the one on 21. I'd need to maybe have LSO look at that and see if that we need to make that conform, or if that's abuse is indeed what they're trying to address here, and not a disorder.
thank you.
Okay, let's just mark that as that's really a cleanup amendment. But so page 16, line 5, I'm going to start keeping track of these. Okay, Representative Larson, do you have anything brief that you want to say before I let people ask you questions?
No, I don't have anything brief, but I would, in fairness, and I appreciate the courtesy of the chairman, I would just suggest, Madam Chairman, that I don't know that you've spent a lot of time on the history and the discussion on why we done what we done.
No, that's good,
I'd be
Colleen. Go ahead.
happy to do
Go ahead and
that.
give us that background. That'll, yeah.
But if you don't want that, that's fine.
That's fine, Representative Larson. Certainly, those of us who've been here for a while have probably, it's probably good to not assume. Go ahead, Representative Larson.
Well, I think, Madam Chairman, taken away from just the structural changes that we got in there, this is a pretty big shift in what we're doing as establishing policy on what the state's responsibility for mental health is. The background on this is, since Chairman Wilson and I have been in the legislature, there's been an ongoing discussion on, we fund mental health at about 100 million a biennium. What are we getting for that funds? And so you had two opposing opinions on this. We overfund mental health. The other side was, no, we're not doing near enough for mental health. Neither one could provide really good documentation of how that was being delivered or what the deliverables are. We've made several attempts to reduce funding. We've never reduced that. We've made numerous attempts to increase funding. That it's just kind of been these two opposing forces moving forward. At the end of the day, we just really, the providers and the legislature really didn't have a clear policy and statute to tell us what was expected of the community mental health providers, other than how it was established. The community mental health system was established in 1979 at a time when access through insurance wasn't really available, as long before the Affordable Care Act, and people, it wasn't one of the required coverages of insurance. If you did have health insurance, in fact, it probably didn't cover that. And so the way it was initially established with our community mental health providers was to allow people to come into the system, be evaluated, receive mental health, and depending on, they could accept money, they could accept insurance, they could accept Medicaid, and they could also then receive state funds to help cover the cost for those people that couldn't afford it, based on a sliding fee scale. And that was kind of an open door policy. 79 is a long time ago, and we've changed. And so this subcommittee said, how should this look? And I think the concern that a lot of people have is, you guys are coming in here and you're not going to fund mental health, when in the reality of this bill, we don't reduce any funding to mental health. I think the concern is that for the most part, the argument is a good portion of the population that really needs mental health is not getting services. And those are the people that are coming out of the judicial system, coming out of the state hospital. Those are people that have long, serious and persistent mental illnesses in our community that we lose track of when they come back into the community. We're not doing that, and that's largely because they're difficult, and we don't have in our reimbursement back to the community mental health centers don't incentivize working with these people. And so this subcommittee, working with the providers and working with the Department of Health, went through several exercises, and we said, so who are the people that the state should be serving? And it was an interesting process and those were done independently. We didn't do it all in one meeting. The Department of Health done theirs, then they provided one for the community providers or the community mental health centers. Then they done one with our subcommittee. And it was really interesting that the similarities were very close. We need to keep people out of corrections. We need to divert people from state facilities. We need to have services to where we prevent recidivism, where they don't go back to prison, where they don't go back to the state hospital, and then we keep them out of our county jails, and we keep them then we keep them on their medications if they're indigent and they have services. We have silos, as you are well aware of, between agencies, and in the Department of Family Services, we have this need for families who may be at risk of having a child be removed from the home, for them to get counseling. But their access, we bring them in and we kind of knock down that silo, and we have them as a priority population. One of the interesting points when we develop the priority populations in here is we set up the tiers. So this tier 1 is kind of the most important tier that we have of the priority populations, and a tier 2, and then a tier 3. Tier 1 has all of those lists. If you look on page, I think it's 11. That's the definitions. But if you looked on page, if you look on page 11, tier 1 is A, B, C, D, and E. So there's 5 groupings or 5 populations in that tier. And the reason we've done that is because, for example, you may live in a county that just traditionally receives a high level of state justice involved people coming out of the prison system. If you have a correctional institution in your county, you probably see a larger percentage of these than a county that doesn't. Whereas you may live in a county that doesn't see that, but has a higher number of adults with acute mental illness for whatever reason. And so this tier with these 5s is to give flexibility to the behavioral health centers so that they can say, in our community, our number 1 priority is this population because we have the most of them. And that's because when they go in and they develop the reimbursement, they need to have the flexibility to move those populations around within the tier. And so we and this was really developed with the help of the providers that we have now.
Representative Larson, let's pause there for a minute. I'm getting a couple of hands. Representative Stivar.
Thank you, Madam Chairman. Representative Larson, the question I've got is the community mental health centers are already going to be taking a huge cut coming up before this goes into effect. Aren't we overtaxing the system now? And what's that going to affect the community mental health services on top of this big cut they're getting, about $15 million cut?
Madam Chairman.
Representative Larson.
So Representative Stivar, thank you. You threw one low and right over the middle of the plate, because that's exactly why this bill is important. And I'll come back to where they're at in the current budget, but in a time where you have fluctuating resources, what's the priority? who is it that the state should be providing mental health services to? And as our statutes currently exist, there is not an emphasis on these priority populations. And we're saying if you have limited funds, if you have a lot of funds, what are our priority populations, who should be served by these services from the state? And so, just a reminder, mental health in the governor's budgets did not take a step 1 nor a step 2 reduction. The only reduction coming to mental health is in step 3, and it is significantly less than the other the groups. But you're right, and so the question should be, which is really a little bit different, is should we have reductions in mental health or not? That's kind of a separate discussion. But if you are going to have reductions in mental health, who then should receive those services? Now, the question on the current funding to mental health and the way this would be structured, I think really will clean up and help address those challenges. I think leaving it the way it is, I think what you will do is put more of those populations who we really have identified as priority populations, who are currently not getting the services that we really think that they should have, will get even less services.
Representative Connolly.
Thank you, Madam Chairman and Representative Larson. And actually, my question is a follow-up to Representative Stivar. When you were going over kind of the rationale, one of the comments you made was that there was no cut in kind of mental health budgets. And I went and grabbed my budget, and I see something very different. And so I'm kind of looking at kind of page 5 of the Department of Health budget. I'm looking at behavioral health, code 2500, and see 11.7 million cut in step 2 COVID reductions, another 10.8 in step 3, a little bit put back when it comes to the supplemental request for a pretty big cut, an enormous cut, tens of millions of dollars to the behavioral health budget. And then when I turn to kind of the more of the detail, I see those budget cuts coming with step 3. And so I'd like to know a little bit more about that comment that there's no cut to behavioral health in this bill. And this bill doesn't have the cut, but there are enormous cuts to the Department of Health, and in particular in the Behavioral Health Division, from reading the budget itself.
Representative Larson.
Thank you, Madam Chairman. And the Chairman Conley, you may correct me. Step 2 cuts, I'm just looked one time. And I've gotten kind of my cheat sheet there, but I had in my mind without looking at that, and it is my agency, so you've kind of caught me standing flat-footed a little bit, but I had in my mind that mental health was not required to take a step 2 cut, and there was a step 3 cut. The point, but I think that this is really an important component of the conversation, Representative Conley, is that in the event that you have significant cuts that we're seeing in the supplemental budget, how then do we make sure that the people are getting these services, and by whom? Now, I think this section 4 of this bill really comes back to say that because this doesn't go into effect until 2022, that the Department of Health with the stakeholders then will determine how the reimbursement and how this really comes into play based on the policy and the priority populations we have. Now, I think it's fair to Madam Chairman and Representative Conley and even back to Representative Stivar, the conversation about this year's supplemental budget really is a separate one, although it impacts and is impacted. But what we do with the reductions to mental health is one that we certainly can and should have a discussion on the floor on what we're going to do. Is it warranted to take all of the step 2 or the step 3 cuts? And what are we going to do to address that? But this bill does not reduce funding.
Okay, Representative Larson, did you have any more that you wanted to say before I interrupted you for questions?
No, I would just say that the component that I was getting to, it really is this point that that we set this out for a couple of years, because in other major policy issues that we've dealt with, such as the waiver redesign, which is, was a similar discussion with the budget, and fortunately we kind of have that prioritized where we can address those as we need to. But this won't take effect for 2 years. And so the second part of this is, as this bill passes, if we get it passed, then it lays the foundation then for the Department of Health with the stakeholders to say, okay, then how do we implement that across this across these service providers to accomplish the task we've been given by policy. So I think it really clears up. I think that it's a great discussion to have. Again, Madam Chairman, I will just share with you that there was a lot of discussion. Well, I won't go there. I was going to get into the, I'm looking, Representative Conley, can you see me looking at you in the eyes? I was going to get into, and Representative Starbar, I was going to get back into the budget discussion, but that really is separate from this bill. And so I will resist the temptation to do so.
Right, thank you. And certainly committee, we have opinions, all of us, I'm sure, about where mental health funding should be. However, as pointed out, that's not part of the bill specifically. Okay, any other questions for Representative Larson before I bring in Representative Hallinan?
Thank you, Madam Chairman. Representative Larson. Now we're turning this money over to the behavioral health centers. Aren't they the ones that are going to decide what the priority is on which patient that comes in? Is it up to them, or is it up to the Department of Health, how this money gets divided up?
Representative Hallinan, just to clarify, are you saying that the behavioral health center will evaluate the patient and discern what category they fall into? Or could you just clarify what you mean by what you think the behavioral health center is going to do?
Well, I think that, we've set the priority levels by this bill. And doesn't the behavioral health center do the deciding which category they fit into? And their money, and the money gets spent according to their criteria that they set up. So I just wonder how that's going to work.
So I think, let me just rephrase, and Representative Larson may not be, we might have to call upon someone else, but I think in general, the contracts that the department signed, and actually Stefan Johansson may have input on this too, but the contracts that the Department of Health signs with the behavioral health centers, they've got various deliverables, and like any healthcare thing, I'm sure you have to have documentation. So, for them to, let's just say, see a whole lot of 25-year-olds who wanted marriage counseling and basically pretend that they were fresh out of the prison system, would probably have very bad consequences when they were audited. But Representative Larson.
So Madam Chairman, if I may just inquire back to Representative Hallinan, I think you're asking the question on the bill as it's structured, where we establish what the priority populations are. And then when an individual comes in to a behavioral health center, is your question then at that point, it will be up to the behavioral health center to determine where these people fall in those priority populations? Am I rephrasing that accurately?
Yes, I think that's, Madam Chairman.
And so I would, Madam Chairman, I would just suggest to you that there's actually kind of some outliers, some precursor information that's available to the community mental health centers before they do all of their evaluation. For example, if there's been a court order for somebody who is, or they've been non-justice involved at risk of harming themselves or others, we know that there's a need then to divert them away from to the state hospital. And so I think that there's kind of, you're right to a point that they're going to have to assess and see where these people fit in the program, but how they're referred to the behavioral health centers will also determine kind of as a determining factor. If they're coming out, for example, if they're coming out of the corrections facility with mental health, well, that's going to establish part of that fact that they're in a priority population that's been justice involved. If we know that they have been at the state hospital and are now released and coming back to your community from whence they've never lived before, because they've got relatives there, the communication now will be with the state hospital and your behavioral health center to say, we have this person that is coming out of the state hospital. So there's this precursor or this predetermination that they kind of fit into this justice involved priority. And then they're going to have to determine at what level they need to keep them stable to prevent recidivism, but yet maintain perhaps some long-term stabilization care. And so there's kind of the way the priority system is set up again is that how they're referenced to the community mental health center determine part of it. But then to your point, their evaluation will also determine if they do or do not fit into a priority population. And Madam Chairman, if I may also, some of that seems a little fuzzy, I believe is, and if you go to section 4 of the bill, where the Department of Health and the community where the providers, the stakeholders, work over the next year, is to clear that water up and say what are the deliverables for these people, and how do we really ascertain where they fit in a tier or in a priority population. Step 2.
Any more questions for Representative Larson? Okay, Representative Larson, we surely hope that you will hang around in the waiting room because you know how we are. All right, Donna, let's see if Director Shannon would like to make a few brief comments or answer questions.
Mm-hmm.
Good morning, Director Shannon. How are you?
Good morning, Madam Chair. Good morning, committee members. My name is Dan Shannon with the Department of Corrections. Madam Chair, I signed in just to be available as a respect to the committee to answer any questions.
Very good. So Director Shannon, Head of Department of Corrections, any questions for him? Well, no. Very good, but don't go away. I mean, we'll put you back out there. You can pick up your other work again, but you know how you haven't been with us that long, but you'll get to see how we are. We'll probably call upon you again sometime.
Madam Chair, I'll be waiting. Thank you for allowing me to. Thank
you. Deputy Director Joe Hansen from Department of Health is there. Let's bring him in. Let's see if we have any questions for him. Oh, Stefan, there you are. Okay, any very brief remark? Otherwise, we will see if there are questions.
Madam Chairman, members of the committee, Stefan Johansson with the Department of Health. Appreciate the invitation this morning. We're supportive of this bill. Happy to get into the weeds or answer any questions if you'd like. We've had numerous conversations over many interim periods on this. I would just briefly mention that with the discussion between Representative Larson and Representative Connolly, this is a philosophical change and a policy change for the state that's less about, how much do we fund mental health and substance abuse services, and more, what do we fund with state dollars? We do believe that at the Department of Health, we run into, as do our other agencies, our communities, really struggles with access for certain types of populations that tend to be higher need or higher acuity. And all of you in your various communities know the struggles that your providers and your local stakeholders face with finding services for Title 25 clients, Title 7 clients, corrections clients, high needs children and families, low income indigent clients. There's just not all of the services and infrastructure available in all of our communities. We know that's reality in Wyoming, but we believe this bill is a tool to help start to recalibrate and retool the community mental health system to provide as much of a safety net as we can with the state dollars to the folks that are most in need, and then leverage other sources, federal funds like subsidized insurance that we totally admit is not always perfect, but is certainly more available now than it has been in the past. So for both the service delivery reasons and the needs of that higher acuity population that we really do struggle to serve as a system, and the budgetary concerns that I know we're all facing, that we have to do more with less, we believe this bill is a start to design a system that can do more with less for a very targeted population, and then leave it up to the policymakers on the funding side of how much money is in this system. But the clarity of the state policy for who we serve and what we provide with state dollars is appreciated in this bill from the department's perspective. And Madam Chairman, happy to answer any questions that the committee might have.
Representative Stivar.
Yes, Madam Chairman, I would like to go back to Mr. Shannon.
Representative Stivar, we sent him away already. We will finish off with Representative Johansson first. Representative Hallinan.
Thank you, Madam Chairman. I guess I'm still not quite clear on how the billing goes. So a patient comes to the mental health center and gets seen and is decided that's a priority patient. Then they send that bill to the state Department of Health for reimbursement, I guess.
No,
Now,
Representative Hallinan, this is a block grant program. They have a contract and they get a set amount of money. But Mr. Johansson, flesh me out. I might be misstating slightly.
Madam Chairman and Representative Hallinan, I think both correct, and it's a bit complicated, but to put it simply, right now it is mostly a grant-funded system with deliverables in the contract, like quota of certain number of outpatient hours of service, or on the residential side, certain availability of beds for substance abuse residential services, for example. This bill would move us to more of a hybrid system. So if you think about it in two poles, on the one end, Representative Hallinan, if you think about Medicaid, financial and disability criteria and other criteria determine eligibility if someone qualifies for Medicaid. And that is determined strictly through an eligibility system that an individual applies for. They go through that eligibility system and we determine if they're eligible for Medicaid. On the community mental health side, as Chairman Wilson mentioned, it's a grant fund, a block grant, so to speak, out to a certain number of providers with deliverables. So those are the two kind of extremes, and this would be a hybrid approach. So that would be designed over the next interim or potentially 2 interim periods, where we would work with our communities and our providers to determine, do we have strict eligibility? For example, is there a system where we determine if a client is under that federal poverty level threshold that's articulated in the bill? Or is that something that we have the providers do and then we do a spot check or an audit? So that's one element. The other elements would be designing how we determine and what documentation we require from the provider if someone was justice involved. So Chairman Wilson mentioned, was there a court order in a previous 6 or 12 month period? Those are all things that we have in place in other programs that we are, as a department, one of the things that we're good at doing is to determine, based on some kind of documentation, determine how to basically qualify someone as eligible for state funds or state services. But this would be a kind of a multi-pronged hybrid approach based on what you see in the bill, both financial components, clinical components, as well as more social or legal components that, again, we have a lot of experience, whether it's Medicaid or Title 25, for example. We require providers to submit us emergency detention documentation before we pay a claim. So this would be a little bit of a mixed bag of all of those things, Representative Hallinan, but something that we're confident over the next interim period we could design in conjunction with our stakeholders.
But for the most part, Mr. Johansson, it's not what we think of as a fee-for-service system. I mean, you don't see a patient and then send a bill off to the state for a half hour of this for a person with these diagnostic codes. You screen them for eligibility, but then they just provide the care as essentially seems best in their clinical judgment. Isn't that right?
Madam Chairman, that's correct. And the other element that would be added to this system, again, I believe it's in section 4, I might be mistaken, of the bill, that we are in that interim period, in that stakeholder engagement period, to also look at implementing kind of a pay for performance or an outcomes based payment system in addition to the infrastructure and services that would be paid for. How do we pay for better, socially determined outcomes for folks who might cycle through the state hospital or the corrections? And Representative Hallinan, that's another element of this, again, a kind of a hybrid approach in a grant, what's historically been a grant funded system, but now introducing some eligibility components into that grant system.
And kind of a bonus system in essence for the outcomes.
Madam Chairman, absolutely correct.
Representative Hallinan, did you have a follow-up there?
Well, I guess my question would be the amount of money that is made available by the legislature for mental health programs. There's a limit that is given to the behavioral health center, and they have to live within that limit, regardless of what the priorities are.
Mr. Johansson.
Madam Chairman, Representative Hallinan, currently, yes, it historically has been, to make it really simple, and it has fluctuated, around $100 million per biennium for this system. So it's actually our second largest line item of general funds in the department. But yes, basically that money goes out in the form of contracts with certain deliverables for outpatient service hours, residential beds, et cetera. With this, it would be similar in how that would work. Again, introducing some eligibility components, but conceptually, this bill would narrow that population, that eligible population. So, whatever the policymakers, that's the business of the legislature, decide to do with those budgets and the appropriations. In concept here, we would be using state dollars to better serve a narrower population, so a smaller population, as opposed to using those dollars to serve more people through general access that might be less acute.
Representative Hallinan, any further follow-up?
No, I don't think so. Thank you, Madam Chairman.
Representative
Thank you,
Clifford.
Mr. Johansson.
Representative Clifford.
Thank you, Madam Chairman. Director Johansson, so the purpose of this bill, you stated, was a philosophical one, and I think I may have got it, you can correct me if I'm wrong, is also a policy change. Representative Larson did say this would take about 2 years. Is that enough time for you to implement and roll this out? Is that enough time? Thank you.
Mr. Johansson.
Madam Chairman, thank you. And Representative Clifford, that's a great question. The more veteran members of this committee know me as an optimist. I do think we can hit the targets and the timelines that are conceived in this bill. But I wanted to remind the committee, especially some of the new members, this work was really modeled off of the Department of Health Facilities Task Force that has been in place since 2014, that was responsible for really redesigning the state hospital and the Life Resource Center, both in the physical plant as well as the role of the state for providing institutional services to a certain population. It's important to remember that through that task force period, this is kind of how the process worked, very similar to what we're discussing now, where the task force conceptualized and set the state policy and sent the department and the various stakeholders to work over the next year to begin designing and implementing. And that task force and the various work groups came back in that interim period and said, here's the changes we need. Here's the timeline adjustments we need. Here's funding changes or eligibility systems or whatever the case might be. We anticipate going through a very similar process, Representative Clifford, if this bill were to pass, to design those elements. And I certainly want to hit those dates and those targets, and I think it's feasible. But I want folks to know that the facilities task force and the broader legislature, I think, went through a very good process with the facilities to be able to be adaptive and realize that we'll run into things that we might need to change. And that process has been unfolding for the past really 6 years with the facilities, but we cut the ribbon at the state hospital last year. We anticipate cutting the ribbon at the Life Resource Center this year. So these things take time, but we took one bite of the elephant at a time, and that's what has, I think, gotten us to the point that we are now with the facilities. And I anticipate Representative Clifford going through a similar process here.
Okay, any follow-up, Representative Clifford?
Yes, I do. Do you think this rollout will hinder any tribal programs or service delivery of the people of my district, House District 33, which encompasses the Winter Reservation? Because there are tribal programs that provide services, and you can correct me if I'm wrong, but they may receive some state funding as well. And then do you think there is a need, should there be language in this bill and how it applies to Indigenous people? And has there been consultation with the tribes regarding this bill?
Mr. Johansson?
Madam Chairman, Representative Clifford, to your first question, in this process of designing and implementing a new policy, a new state policy here, I don't anticipate any impacts on the current funding for tribal organizations that would receive state dollars for mental health or substance abuse services. Tribal members, as you know, are priority populations in various programs that we have and funding that we have for behavioral health in the department. That would certainly continue from the department's perspective with a bill like this, where within these priority categories, we would be looking to, if this bill were to pass, with these dollars to serve folks who meet these conditions or meet these eligibility criteria to the best of our ability and achieve those outcomes like reduction on institutional services, employment, education, things like that we know socially are very important for behavioral health related outcomes. The subcommittee, to my knowledge, and Representative Larson can weigh in here as a representative from Fremont County, I believe heard testimony related to the tribes, but I'm not sure, Representative Clifford, if specific consultation was undertaken with this bill in its initial phases.
Any further follow-up, Representative Clifford? Okay. Representative Stivar? You're muted still.
Thank you, Madam Chairman, Mr. Johansson. Question I've got is, how does this fit into the Olmstead Act, decision from the Supreme Court, in the Chris S. lawsuit? Because it says that we're not supposed to be using jail for this. So how does all this fit in? This bill fit into that? Have you guys discussed that?
Mr. Johansson?
Madam Chairman, Representative Stivar, that is a fantastic question and one that's near and dear to my heart. Specific to Olmstead, for certain populations that we want to reduce reliance on institutional services, that's really the heart and soul of the Olmstead Act. From my perspective and from the department's perspective, I believe this bill will help us be more Olmstead compliant and Olmstead informed as a system because of the targeting and the focus on populations that might by no one's fault, just by the system and the funding models limitations, might have to rely more on the state hospital, the correctional system, the Life Resource Center, for example. If we can start to retool and fund our community providers to target services to that type of population, I think we can do well as a state to reduce our reliance on those higher levels of care, which Olmsted really tries to prevent. So that's certainly my perspective and the department's perspective, but I know that other agencies might want to comment on that as well, who are involved with Olmsted.
Representative Clifford, did you have another question? I think, because I didn't make myself a host, I can't, I don't think I can put the hands down. We might have to let Donna, you might, if you make me host, I can at least put people's hands down, even if I still let you bring in the people.
All right,
Okay.
I made you a co-host, Chairman Wilson.
Thank you, Donna. Any more questions for Mr. Johansson? And then we will go back to Mr. Shannon at Representative Stivar's request. Okay, thank you, Stefan. I'm sure you will want to hang around. No escape. Director Shannon, thank you. Representative Stivar had a further question for you.
Yes, sir. Through the chairman to Mr. Shannon. Question I have for you is, we passed House Bill 31 last year. With the way this is written for the corrections, what's your information? And did you get any feedback from the Council of State Governments on this?
Director Shannon.
Madam Chair, I'm Dan Shannon, once again from Department of Corrections. Representative Stivar, we did receive feedback from the Council of State Governments on how it affects the concerns that they have was the limitation of 6-month periods, when the data clearly shown that it was more effective to be beyond 18 months. The Council of State Governments also strongly supported the fact that the prioritization of those who needed the services the most, because supervision under as well as treatment at the same time is really clearly effective. If we look back as far as some data with the House Bill 31, we had 467 felony probation, felony revocations in 2019, of which 281 were directly related to substance abuse. And 2020, now there was some effects as far as, the COVID pandemic. This was after House Bill 31 was passed. We had 317 revocations and 184, which is 60%, which tentatively dropped the substance abuse revocations by more than 10%.
Further questions for Mr. Shannon? Representative Larson, you seem to have returned. Representative Larson, did you have an additional remark you wanted to make?
Just a clarifying comment, if I may, Madam Chairman, and it is not on the bill, but was to the point that Representative Conley made on the behavioral health budget, which is correct. In behavioral health, there are some significant step 2 and step 3 reductions, but not in the mental health units. There's some step 3, but not step 2. And maybe Mr. Johansson can clarify that.
Representative Connolly, well, let's just see what Mr. Johansson has to say, and then I'll let you pin them down if they don't answer to your satisfaction. Mr. Johansson.
Madam Chairman, thank you. And Representative Larson and Representative Connolly, that's correct. There were significant step 2 reductions in our behavioral health division, which includes community mental health and substance abuse. But those 4 units, if memory serves, 2506, 07, 08, and 09 were not cut in step 2. So, and as you all know, step 2 cuts are either implemented or in the process of being implemented. Step 3 reductions are currently proposed, and Representative Connolly, you're right, there are proposed reductions to those 4 budget units for mental health and substance abuse, which I believe, and I'll have to double check the number, are around $15 million in step 3, obviously subject to change over the next month with the legislative process.
So Stefan, what were the step 2 reductions to behavioral health that were not community mental health?
Madam Chairman, bear with me. I will pull up all things budget here.
I mean, it could be that Representative Connolly has them right at her fingertips. She probably does, but I want to give Mr. Johansson first chance. While you're looking, well, we'll go ahead and ask Representative Connolly. You seem to have them there. What were they? You're muted.
I do, Madam Chairman, and it was because actually with the presentation, it was said there was no cut to mental health. And the reality is there is cuts to mental health in the 2500 division. This bill is how to implement those cuts. And so on one hand, I was concerned about perhaps a misconstruction of what's going on here, that there are cuts to mental health that are being proposed in the supplemental budget, and that they are done in a step 2 reduction and a step 3 reduction. That, as Mr. Johansson said, the very specific mental health, substance abuse, residential and outpatient are step 3, which honestly start relatively soon. Step 2 are already being implemented. The step 2 reductions included reductions to administration, recovery supports, court supervised treatment, the state hospital, preschool services, and respite care. That's where the step 2 reductions came. The step 3 are, again, the outpatient and residential mental health and substance abuse, all of which are being contemplated in this supplemental budget. And so I think just for me, it's important to recognize honestly, and as you said, Madam Chairman, at our last meeting, is that the desire for this bill, this subcommittee, came from a recognition that there would be cuts, and that how would those cuts be implemented, or the anticipation that there would be cuts. I think the alternative, honestly, is that we fund services. This bill, again, is predicated on the notion of cuts. This is where we see the cuts in the budget. Thank you, Madam Chairman.
Okay, so so thank you, Representative Connolly, for sparing me from having to pull up my Department of Health budget. So there were cuts in round 2, however, they were not to this specific community mental health and substance abuse services. They were in other line items within the behavioral health programming. I will just also sort of throw in there that, yeah, I mean, I agree that the real value of the bill in this fiscal environment is to prioritize in time of cuts. However, let's suppose, some amazing thing happens and we're able to provide a 40% increase to community mental health programming. I mean, let's just say there's still no harm in having a prioritization. Anytime you prioritize, it seems to me that that's not a bad thing. And then if you have money so you can provide general access services for people with insurance, that's fine, but that doesn't have to, I'm saying it's not necessarily an exercise that you only want to do in budget difficulties. Okay, any more? Let's see, were there any last questions for Mr. Shannon round 2? Okay, thank you. And Mr. Johansson, we were done with, so we have Lindsay Schilling from DFS. Morning, Ms. Schilling, how are you?
Good morning, Madam Chairman, members of the committee. I'm Lindsay Schilling with the Social Services Division at DFS. Generally, my comments are brief and then I'll remain available for questions.
Okay.
We're very appreciative of the work that's been done on this bill, and most specifically, the focus on families that's reflected through the definitions on page 8 and 9 in creating that families at high risk category. For a bit of context, in the most recent federal fiscal year, 37% of the kids that came into foster care as a direct result of parent or guardian substance use disorders. So those would have all been neglect cases that would have been handled by the agency. To put a number to that, if I were to take 37% of the total children in foster care today, that would be 336 children. So obviously, any work that is done to promote or increase access to services for families that DFS works with has a direct benefit on the children we serve as well.
Okay, questions for Ms. Schilling? All right, great. Hang around, no doubt, Ms. Schilling, you know how we are. Let's see, do we have any other agency people? I don't see any other agency people. Okay, just to confirm, and again, committee, we have heard from people really for a long time. So I'm not looking to have people give lengthy statements again because we've heard them. However, we do have available for questions Andy Somerville from WAMSAC, Mr. Birkeland, and again, I apologize, I can't remember what organization he's with, some kind of counseling group, I think. Mr. Hackman from the psychologists, Lindsay Simino from the counselors, and Cheryl Foland, who is a counselor in, well, both Lindsay Simino and Cheryl Foland are in private practice counselors. So that's essentially who we have if you have any questions. Representative Stivar, I think you're waving your hand there. And then Representative Colony.
This question is for Mr. Hackman, if you can put him on.
Okay, Mr. Hackman, send him in.
I will admit Mr. Hackman.
Thank you, Donna. Good morning, Mr. Hackman.
Good morning, Madam Chairman.
Welcome back.
Dr. Hollis Hackman, Wyoming Psychology Association, representing the psychologists in the state. I'm happy to stand for any question that Representative Stivar or anyone else might have.
Very good. Carry on, Representative Stivar. What's your question?
Yes, through the chair to Dr. Hackman. Can you discuss the Chris S. lawsuit and what it's going to do to the care of what we're doing here in reducing the care?
Madam Chairman, Representative Stivar, yes, I really haven't, in following this for about the same amount of time y'all have been, I haven't heard much of a discussion about Chris S. Or we did hear a good discussion about the Olmstead Act earlier, but about 20 years ago, there was a court decision in district court in Wyoming, it's U.S. District Court, which addresses several things that are potentially impacted by this House Bill 38. And one of those has to do with properly staffing community mental health centers. And looking at the court decision, it says that levels of staffing need to be appropriate to meet an entire continuum of care, which includes but isn't limited to counselors, nurses, social workers, and psychologists or psychiatrists. We think that has some important impacts in regard to this bill. And let me just mention from the view of the psychologist what that means. This bill essentially prioritizes all the money for mental health services in the state through these block grants to community mental health centers. And community mental health centers don't always employ doctoral level skilled folks like myself or the psychiatrists. And so if a patient's seeking treatment at a community mental health center and they really need somebody with doctoral level skills, and they don't happen to be employed nor are they on contract with the community mental health center, then they're going to come up short with what they need to make a good differential diagnosis. And then what follows from that is a good comprehensive treatment planning process. If you don't have that, then you can get into this circular doors circumstance with hospitalizations and then discharges from the state hospital. This bill also prioritizes the gatekeepers. I mean, the people that help with this case management of folks in and out of the hospital system. It prioritizes that to the mental health centers. And again, that's problematic if you don't have doctoral level people on the staff at those mental health centers. So we're concerned that doctoral level folks, that arguably the most highly trained mental health folks in the business, aren't going to be available in this plan. And so there are concerns about that.
Dr. Hackman, if I can interrupt there. So I guess, so you're saying doctoral level people are not available at community mental health centers now?
Madam Chairman, yes, that at least when I was at a legislative briefing here just a couple of years ago, we heard from the CEO of Northern up here in Sheridan County, Paul Demple, say that they don't employ psychologists because they can't afford them. And Andy Somerville can chime in here if you want to bring her into the room, but I am relatively certain there are mental health centers that don't have doctor level skills or doctoral level folks on their staff. And that's potentially, we think that's problematic. We think that may run afoul of this Chris S. decision.
So I guess my question though, Dr. Hackman, is how does this bill change that? If the psychologists are not there now, and we're saying for the same amount of money, see the most severely needy people, how is that, how would that be different?
Well, what we see in this bill is a tightening up of how the money flows. And so it really makes it so that if a patient wanted to make a choice in regard to a private versus a public provider, they can't really make that choice anymore. They're going to have to go to the public provider because all the funding goes to the public providers. And so the state's not providing any access to resources to provide for funding for private providers.
But Dr. Hackman, this is about funding that goes to the community mental health centers now. So I mean, it's not like we're taking money away. It's you are not a recipient of a state grant dollar now, are you?
Madam Chairman, that's correct. But the bill just tightens up that prioritization process and just makes it even less likely that there's a chance for private providers to provide services. So we're concerned about that, but we're all, and this does run kind of afoul of the Chris S. decision 20 years ago that basically says folks need to be able to have a choice. And so what we see with this bill is there's a reduction in choice for patients in terms of who they seek for providers. And we're also concerned about limits on access to care. So I'm not sure if I'm clarifying anything here.
No, you are. I'm just giving you a little bit of a hard time, Dr. Hackman. I guess what I'm seeing is that you want to have as much chance to offer pro bono care as anybody. So we could put that in. Require all private providers to provide 20% pro bono care. That would be something. Any more questions for Dr. Hackman? Representative Stivar.
Follow up, Madam Chairman. So do you believe this bill is going to reduce the care of the people in the state of Wyoming?
Madam Chairman, Representative Stivar, we are very concerned about that. Yes, we are. We think access to care is going to be reduced and patient choice of provider is going to be reduced.
Thank you, Madam Chairman. Thank you, Doctor.
Any more questions for Dr. Hackman? Okay. The other people that we had in the waiting room, as I said, were Andy Somerville from WAMSAC, Bruce Birkland, Lindsay Simino, Cheryl Tholand. Any questions for any of them? Representative Connolly.
Thank you, Mr. Chairman and Madam Chairman. I think my questions would be, actually, it would be fine if Dr. Hackman stayed on, but for Ms. Somerville and Ms. Simino, I think is how to spell her name. Say her name.
I finally learned it. I believe it's Simino.
Simino, okay.
Dropping that last E, yes. we don't have to sound it out phonetically, I guess. All right, well, we'll just let them in, keeping in mind that, yeah, okay. All right, Representative Connolly, what question did you have?
Thank you, Madam Chairman. And actually, I have two, and they're different. But one is about the process that happened, and actually Representative Clifford asked a process regarding kind of inviting the tribes to the table here. And I am curious about the process for this bill. And honestly, my perception that though it has been in the works for years, it was really done with the notion of you folks better get ready for some cuts, and either you get to be at the table and talk about it or not. And that was your choice. And so I call it the difference between, do you prefer a punch in the stomach or a punch in the face? And that isn't really a choice when the other option is funding necessary services. So that's my first question. But my second question is very different. And it is about the prioritization list. And there is a concern from my county attorney, for example, that in my county, there has been an attempt that this bill.
Wait a second, Representative Conley, because this is a kind of a long question. So let's answer the process one first. And then come back just to make sure that everyone remembers what the question was, especially seeing as we have got 3 people now that could potentially answer that. Okay, so did you want to hear from all of these 3, or did you have a specific question of Ms. Somerville and Ms. Semino, or?
Madam Chairman, I think each of them has been participating, so I wouldn't mind hearing from them.
Okay.
As a new member of the committee here.
Very good. Ms. Semino, I'll just pick you first. What was your perception of the process?
I actually, Madam Chairwoman, Representative Conley, I would actually default to Mrs. Somerville first. She was, I think she was brought on first in the process and had the most involvement within the process. And so I actually think that for the process piece, Ms. Somerville would be able to answer that without causing me or Mr. Hackman to repeat ourselves.
Very good. All right, Ms. Somerville.
Thank you, Madam Chairwoman. Representative Conley, Andy Somerville with WAMSAC. I appreciate the question about the process. So we started working with the joint subcommittee when it was formed, I believe in May of 2020. We presented at all of those subsequent meetings, and maybe Chairman Wilson can help me. I can't remember if it was 4 or 5 of those meetings during 2020, just on basic kind of education about what the community mental health centers do, what that funding looks like, how we use the funding. And then we participated in 2 stakeholder meetings with the Department of Health in terms of, I think, that process that Representative Larson described in prioritizing or coming up with a list of prioritized populations. And then I believe we ended up with a bill later in 2020. So it did move quick. To be very honest, moving a system like this is never easy. It's large. The funding can be somewhat complicated when you're dealing with weaving in state general funds with federal block grants and all the other funding sources that the community mental health centers do. But that's kind of how we ended up where we are today.
Ms. Semino, anything to add to that?
Madam Chairwoman, no.
Dr. Hackman, anything to add to that? Just briefly, Madam Chairman, if we were invited to be involved in the process, I missed the invite, but we're available and want to be actively involved as much as we can. One has to stay alert, certainly. Okay, so Representative Colony, now you can circle back to the and I'll just say as a member of that subcommittee, and I don't recall either if we met 4 times or 5 times, you know, followed the usual legislative process of posting and agendas and all that sort of thing. I think we pretty much at every labor committee meeting, I gave an update on the labor committee. I was on it. Senator Bouchard was on it. Representative Barlow, and I think Senator Schuler was the other Senate member. So we had 2 House Labor, anyway. So every labor committee meeting throughout, we also reported back to the labor committee on where we're at, you know, what was the process. Okay, Representative Connolly, then the next question.
Thank you, Madam Chair. And again, this is a very different question. And it is actually about the priority list, and in particular as it relates to those who are involved in the criminal justice system. And it appears that there was a very conscious choice to address issues of recidivism in this bill, and that those who have been involved in the criminal justice system would become one of the priority populations in order to kind of maintain public safety through having services so that there is lessened recidivism. I have had conversations with, for example, my county attorney, who very much questions that choice and what's going on in our county in order to address public safety. So the first point would be those services could and should be available in our jails and prisons. We have cut those right now in the Department of Corrections budget. So there is the understanding that there's an absolute need for it. And so in some ways, it's been kind of robbing Peter to pay Paul by now moving it out to the community mental health system, right? That's one element of it. But the other element, and that was most relevant to her, is that there has been a real push in my county to do prevention. And prevention at kind of what you would consider lower level crimes and diversion from jail or prison to the mental health system where it is seeing. But she feels like with the prioritization as it lists in here, it's people who have already been involved as opposed to the prevention that she would like to see. And I'd be curious about your take on that choice about those who are already criminally involved versus prevention, which would now be at the very lowest list because somebody isn't identified at that point as a felon or even a misdemeanor. So I'm just curious about that choice and how you think about that.
Shall we start with Ms. Somerville?
Thank you, Madam Chairwoman. Representative Conley. So that's a big conversation. You heard brief mention of it already, but House Bill 31 that was passed last year really highlighted the need for access to essentially DOC-based clients. So either they've come out of an institution or they were sentenced by circuit or district court to supervised probation that is under the jurisdiction of DOC. And so that's a process and a program with that bill just passing that we've just started. And of course, all of those things have spun out of the Council of State Governments work to date, but that process is very much still, I would say, in its infancy in terms of moving that along. One misnomer that I want to just correct for the committee that's commonly held is there's this idea out there that we weren't serving these populations that are listed in this bill, particularly the DOC populations. That's not really the case. We know that our programs for substance use disorder have a high percentage of what we would call criminal justice involved clients from all levels. There was a conscious effort, and I think it was something pushed by House Bill 31 to include them as priority populations. But you are absolutely correct in that there's not really a lower level offender prioritization in this bill. That is something that the groups that have been working on House Bill 31 have discussed as a need, right? Are we starting at the right place? Do we need to start much earlier? Ideally, we need to start much earlier, right? To offer those services. The way the bill is written right now, however, they would have to qualify potentially either in one of those tiers and most likely in tier 2 or tier 3. So that would be your high needs indigent or just your indigent client for general access. And that's a fundamental system change. The community mental health centers right now operate on an open access, essentially, that's really based on your ability to pay. So regardless, you don't have to have one of these specific diagnoses or fit into one of these tiers right now. And that scale has shrunk. I think that's one of the things I want to make sure as we move through this process that we're managing expectations for everybody that's involved. And so I know that I've testified last year about this, but most of the community mental health centers right now run sliding scale fee up to about 300% of poverty level. And so that has shrunk in this bill. So presumably we could, forecast that access and that prevention. So somebody who gets picked up for low-level drug offense or something along those lines that's a misdemeanor that's not going to the higher levels of the system, they'll have to qualify financially to be able to receive those services from their community mental health centers. So with that, I'd stand for any follow-up questions on that particular topic.
Ms. Simoneau, anything to add there?
Madam Chairwoman, Representative Connolly, I think your concern is valid. That has been the concern that I have heard from our membership. We do have a high membership that is employed in many of these community mental health centers. And the echo that we hear is, does this criminalize mental health care? Do you have to have already been in the system in order to receive services? And as Ms. Somerville already spoke to, yes, it does limit that. You are required now to be in a tier population. It does shrink the ability to have that open service in order for our community mental health centers to provide those preventative services that we were able to do before. So as far as those preventative services, yes, you will have to meet one of the requirements within the bill in order to be able to engage in services. And then does that mean we aren't catching people before there is criminalization in place? I think it's a fair concern.
Well, so Ms. Simoneau, if I can interject, that
Sure.
The bill specifically deals with the state general fund money, the contracts that they'll have. So there's nothing that prevents a community mental health center from using federal dollars, county funds, billing for insurance, privately raised funds to provide other services. As a matter of fact, we specifically state at the end of the bill that is obviously, you are a private provider. We can't stop you from providing other services. We're merely saying for the state general funds, this is what we're paying for.
Madam Chairwoman, that is correct. I think it is fair to forecast that there are going to be those that have private insurance that will be able to engage in those services. I also think it's fair to forecast that there's many within that population that aren't going to have that private pay option, whether it is because of unemployment or because of other environmental circumstances that they have.
Representative Connolly.
Yeah. Thank you, Madam Chair. And again, I'm new to the committee, so I'm just kind of curious. If somebody was a tier 1 population person and had private insurance, my guess is that you would bill private insurance, not the state. And
Right.
So I'm a little confused, Chairman Wilson, about your comment, because to me, those people would already be paying if they were in tier 1, and then there's only a set pot, and you're saying who can be served with the state pot, and it's not as if the state is going to pay for those who have the ability to pay otherwise.
Right. The community mental health services, and this was a significant discussion 6 or 7 years ago. They do bill, Medicaid, Medicare, TRICARE, Blue Cross, whomever else they can bill. But so the folks that are kind of down at the bottom of the list now are people with lower level problems who have no insurance. And for those people, we are basically saying, yes, you will have to maybe get county money, federal grant, Robert Wood Johnson, bake sale in the parking lot. I mean, that is admittedly so, but the failing to do that would basically say that maybe a person who just got out of Rollins and has had a history of substance use disorder is on a waiting list for 2 months because they're busy seeing other. I mean, you see what I'm saying? There's a real trade-off here, and it's not just dollars; it's also a number of providers. I see Representative Larson is trying to get in on this. Representative Larson.
Well, I think a little bit as we talk about that, this discussion on general access, we recognize that there's going to be part of the population that are indigent and that don't have access to insurance, and that's why we have the discussion on those people. Where do we set the poverty level at? Do we say it's at 100%, which is that group of people, of course, it's not covered, that would have been covered by Medicaid expansion, that doesn't have access to the exchange. We reached out to the insurance department. They said, well, letter of the law, that's correct, but practicality, you really ought to adjust that to 150%, which is what we've done in the bill. So we have people that if you look at the definition of indigent general access on page 9, we try and provide a mechanism. We define them, and then we put them in the tier 3 of the priority population, recognizing that there's people who are impacted by unemployment, by a variety of things, that don't have access to health care that could qualify as a priority population. However, with all of that said, I think we have to be somewhat realistic as well. What is the role of state government in providing mental health services to the populations of the state? Sure, we should fund it more. Sure, we should fund it in totality, but it's just not practical, and we don't have the funds to do that. That's argumentative, I'm sure, and that's what we hash out on the floor. So who do we serve with the funds that we do have? And the discussion around this bill is we have populations with mental health issues that aren't being served. And so working with the providers, we've identified who we feel those priority populations are, and we establish that to make sure that the state's priority for providing services are to those populations that are defined. I wish we could be all things to everyone. We can't, and that's why we need a policy. That really is why we need a policy. And so we can argue about the injustices of the world till the cows come home, but we still have to have a policy to determine how we're going to use the funds that are available in the state.
Okay, Representative Connolly, did we fully address your question pretty well?
Thank you, Madam Chair.
Okay, so we have the three suspects, so to speak, in our on our screen. We've got Mr. Birkeland, Mr. Foland, or Ms. Foland out. More providers. Do we have any further questions, or have we pretty well exhausted our questions? Okay, Representative Flitner, were you asking a question? I thought I saw your lips moving. Okay, all right, Representative Romero Martinez.
Thank you, Madam Chair. I have some concerns. I guess I'd like to direct this question to Dr. Hackman. He had raised some concerns about public versus private care. Maybe there's like certain individuals or certain populations that will not be able to be serviced. What do you think is a fix for that?
Dr. Hackman.
Madam Chairman, Representative Romero Martinez, I'm not sure what the fix is, but you're getting at again the court decision known as Chris S., where part of the conclusion from that decision was that the patients need to have a choice between public and private providers, and so that's part of that decision. And again, I hope I wasn't involved. We weren't involved in the whole process leading up to this bill for whatever reason. But I hope that the subcommittee and this committee takes a look at that court decision, so that we're not getting sideways with it. And I'm not an attorney. I'm not pretending to be, but but that is addressed in the Chris S. decision.
So I guess, Dr. Hagman, just to follow on that, you know, we're not preventing people from accessing a private provider, but I guess what you're saying is that you don't want to see them pro bono. So if people are poor, you would like the state to provide funding for indigent people to see anyone they want.
Madam Chairman, that's a fair summary. Yes, ma'am.
Representative Stivar?
Thank you, Madam Chairman. This is for Ms. Seminole. What, with you being a private provider and with the budget cuts coming up and with this, how is that going to affect everything? Do you think that's going to affect everything?
Ms. Seminole? You're muted.
Forgive me, I am. I'm usually really good at that. Madam Chairwoman, Representative Stivar. $15 million is, I believe, roughly a 20% tax cut in order for our community mental health centers. And though we do recognize the situation that the state of Wyoming is in, we do appreciate the fact that decisions have to be made. The reality is that we have not seen the actual forecast for how this budget cut is going to impact not just our major big community mental health centers, but our smaller community mental health centers. More than likely, our larger community mental health centers are going to have to take some of the extra load because of those already established budget cuts that we talked about in tier 2 and tier 3, or in phase 2 and phase 3. With that, on top of the priority populations, yes, it's still 2 years out. However, because we do not have the forecast on the budget for the community mental health centers impact with those budget cuts coming up, I cannot adequately answer whether or not this is going to be able to be launched successfully as well across the state, because of that compensation in budgets for our smaller community mental health centers in smaller areas, and with our larger. Does that make sense? That our larger will have to do more of the work, whether telehealth, whether remote, because of these budget cuts.
Okay, committee, I think we've pretty much wrapped up in the questions there. And just to kind of circle back, chairman's prerogative on some of these. Remember, this bill does not specifically address the level of the budget. So we need to make sure that we're not confusing the thought with how much money we put into the mental health system with what the priorities are. We have to be careful that we're not saying we don't want to set priorities because we want to fund everything. I mean, that's a great statement. I mean, and we can, if we have that argument on the floor when JAC brings in the budget, we can say we don't want to have priorities in education because we want to fund everything. We don't want to have priorities for senior centers, for mental health, for disability, for water, we don't want to prioritize anything because we want money for everything. If that's your answer, be sure to vote for all the tax increases. Some of you I know will on this. I'm just teasing you all. But remember that this bill is specifically for state general funds. Do we identify how we prioritize what the state is paying for? That's the question of the bill. So that being said, it looks like we've pretty much wrapped it up. I'm going to close any more public comment. And I think I'm going to give us all about a 10-minute break here so that we can refresh our coffee. And then we will come back at 10:25. And if there is a motion on the bill, I will hear that then. Okay, 10:25. See you back.
No, you just see it as an option. I mean, if you roll it out, you can see it.
Sue, I very much appreciate the ability to get another cup of coffee.
Or to offload the previous one. Yeah. You know, not to cut things short, but you know, we're kind of rehashing the same stuff for a lot of meetings, and I feel kind of bad. I looked at some of the other committee meetings agendas. Some committees have got like 4 bills on yesterday or today. I'm like, well, I think we'll be lucky if we can do one.
Madam Chair, I just wanted to let you know that we are still streaming
Ah,
on YouTube.
so don't say anything bad.
I'll go back to just thanking you for the ability to get more coffee.
I have more coffee as well.
Are we having fun yet?
Representative Stivar, we are always having fun, especially when we're streaming online. I'm really looking forward to seeing everybody in person and just doing our committee work in person. I just think it'll be great.
Yeah, much better than this.
It is so true.
I had a meeting with some people call me up to have a meeting for various things, and they'll be like, we can Zoom. I'm like, please, no.
I will say though, it was good yesterday. We had testimony from somebody who is a neighbor to me, and it was 5 minutes of testimony, but it was very relevant. And normally we wouldn't get that because nobody's going to drive 7 hours to give 5 minutes of testimony.
Yep.
So I do like that piece.
That is true. That is true. I mean, that's a real strength of I mean, I think we have actually expanded citizen access in a lot of ways through this. But I also think that in just doing brainstorming work on the part of committees, trying to pull together, policies and systems and draft bills, it's just hard to do by electronic method. Okay, we're pretty close to back. Let's see, we got 3, 4, 5, 6. We have anyway a quorum. Donna, I guess we'll go ahead and start up. So here we are back to the bill. And I am ready to hear a motion on the bill if there is one. Moved by Hallinan, seconded by Flitner. Okay. Do we have any discussion on the bill or amendments? Representative Stivar. You're muted.
Thank you, Madam Chairman. I'm a no vote on this. If we need to go back and really look at this, because if you look at the Chris S. lawsuit, in there it says the state of Wyoming convinced and agrees that such advancements made in or to facilities and services available to Wyomingers with mental illnesses will continue, and that there will be no regression from the obligation of the advancements that have transpired in Wyoming mental health care systems since initiating of the lawsuit, and further advancements that will be fostered. So to me, we are stepping back. We're taking, this is good. This bill goes against the lawsuit. So I am a no vote on this.
I will just say that seeing as we are prioritizing people with severe mental illness, it seems like that might actually be an improvement rather than have them having be on a waiting list. But okay, do we have any other discussion or amendments? And Representative Flitner, I know do you want to do a cleanup one on that item on page 16?
Madam Chairman, sure, yes. Page 16, line 5, changing abuse to use.
Okay.
And then page, well, it's still in, I guess, and then conforming throughout.
Let's
Based
just stick with that one, and if we find more cleanups for the floor, we, you know, I would, sometimes we change one, like we had an ambulance one back last week or whatever, and we overchanged. So let's
Right.
hold off on that other one just to see. Okay, is there a second on page 16, line 5? Just really a typo, seconded by Connolly. Any discussion? Okay,
Question.
all in favor of that amendment, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9. Very good. No, a 9 and 0, obviously opposed. Bonnie, are you there? Donna, are you able to mark that down? I'm not sure where Bonnie is. Her camera's
Yes,
not on.
I did mark it down. I'm showing that Bonnie's mic is on, but she did send me a text message that she's not sure people can hear her. So
I can't see her or hear her.
I'm trying to turn her video on, but I am not having success.
Okay. Donna, I know you're supposed to really just be there for Zooming, but do you have the amendment?
Yes, I do. I have the amendment, page 16, line 5, made by Representative Flitner, seconded by Representative Connolly, 9 yes votes.
Yep, delete abuse and insert abuse.
Yes.
Or I mean, delete abuse and insert use.
Use, correct.
Okay. All right. I have the larger one about the sunset if nobody else has any other ones. So I sent these out, Representative Stivar. You're muted. Oh, there you go.
Yes, Madam Chairman, I want to amend the effective date till July 1st, 2024,
What page are you on?
page 25.
So are you leaving the reports and the rulemaking as they are?
Yes, ma'am. That way we can, we get a chance to look at it and make sure if this does pass, that it's what we intended.
Okay, so the motion on page 25, line 20 is to delete 2022 and insert 2025.
2024.
2024. Okay, is there a second? Seconded by Worf. Any discussion? Representative Flitner.
Madam Chairman, thank you. I'm just curious above that in subsection C where it speaks to the Department of Family Services. Should that also be changed to 2024?
So it looks to me, let me just see, let me just back up and see where the other rulemaking is.
Thank you, Representative Flitner.
And Madam Chairman, if I may ask Representative Stivar just to speak to this amendment and his reasons a little more clearly, please. Thank you.
Yeah, let me just, and Representative Stivar, I'm looking now, I'm not actually seeing a rule. I would think that there must be a part in here on rulemaking for the Department of Health. And I'm not finding a date on that, just so that we are consistent. You know, we have they're reporting to us on July 2021, DFS 2022, you know what, and I don't actually see a rulemaking for the Department of Health.
Madam Chairman,
Representative Flitner.
on page 25, line 13, it does say the Department of Health and Department of Family
Oh,
Services.
there you go. I didn't see the health there. I just saw family services. So what we have existing is right now, the department is reporting to us, to this committee, by July 31st on the discussions, the findings, the recommendations. And then we're asking them to do rulemaking, but not making it, but then the amendment would not make it effective until 2024. You know, I almost wonder, and you know, we'll carry forward that. So in discussion on the amendment, Representative Stivar, you know, the desire obviously is to see what, so what we're asking them to do the rules, and then it becomes, I mean, I'm not sure if we want to have them make rules, but it's not effective for 2 years. I almost wonder whether on page 24, line 16, I'm not making an amendment yet. This is just part of the discussion. We might want to have their discussion put off so they don't present to us until, say, October 1 or something, so they could give us a report on what kind of rules, you know, just that would give us more report. And you'll see when my amendment comes around, as far as the sunset date issue, that they're going to have another report on the prioritization. I'm not sure that it's that helpful to have them promulgate rules and then delay the effective date of it all for 2 years. I mean, that seems like that could just be sort of a strange hang fire. I don't know. Any other thoughts on this?
Madam Chairman, the reason I want to, I just put it out in 2024, you know, because they need to promulgate the rules, and I do believe this is a very complicated matter. And once they get the rules and they present them to us, if there needs to be changes, because it's not implemented the way it should be, or we don't think it should be, we get that changed and let them go back and rework them. Because if this doesn't work out right,
The thing is,
a lot of people
might know better, but once the rules are promulgated and those are signed off by the AG's office and the governor, then we don't really have, I mean, then they've got the rules promulgated. I'm not sure that fits with the structure of rule promulgation. Representative Connolly, you've been here longer. Do you know anything about that?
Madam Chairman, I think you have it right. That is just the process, and that there is the ability for public comment during that rule promulgation, but that's about it.
Representative, so we'll take a vote on the amendment. I think I'm really not certain that putting out the effective date after the rule promulgation is really what we want. I almost wonder this might work better as a floor amendment when you can really check with sort of the rulemaking type people and see if that works.
All right, because Madam Chairman, I'm the one that, if you all remember right, I'm the one that put the sunset date in.
Right, and my amendment on that will be coming.
I did that. I admit it. All right, but that was why I did it, so we could look at the rules and make sure this program was working properly. And if you remember, Senator Scott, co-chairman at the time, thought that was the greatest amendment all day. I'll never forget him saying that. So that's why I want to set it out. So I'll withdraw my amendment at this time.
Is that okay with the second? I can't remember who seconded. Okay. So, and Representative Stiver, I understand what you're trying to do, and I don't disagree really. I think we just need to make sure that the functioning of the oversight works in the way that we have the oversight. Let me bring forward the amendments. The part of this discussion has to do with the sunset. So let me bring forward my two amendments here now, because that fits into what we're doing here. So as you received two amendments from me, and it's just broken up for because one was a deletion and one was an addition, but you should have them both in your inbox. So during the interim committee, there was an amendment, which was Representative Stivar's, which passed, to have a sunset date on this. And the desire, and Representative Stiver, if I'm not representing correctly your thinking, please feel free to say. But the Representative Stivar's desire, and of people on the committee who were not entirely sure about this, was to make sure that we had a chance to look at it again. Fair, totally fair enough. However, because what it turned out afterwards, as a kind of LSO came to me, because we did have a sunset date, which is on page 1, you'll see the word sunset, and then we have that it's repeat this 31-1, 611 through and so on are repealed 2026. And there were also insertions throughout the various Title 25 that such and such is only effective from 2022 to ending 2026. Because of the way the bill was structured, what that actually ended up doing in that repealer on the top of page 2 is it sunsets the entire community mental health funding and programming in 2026, in 5 years. And we would all like to think that 4 years from now, in the 2025 session, we will all be there and brilliant and remember what we did and that the sunset will be brought to our attention. But if we failed to send a program forward, then we would have actually no community mental health program at all, which I am really quite sure is not what anybody wanted to do. So what I have done but I fine with Representative Stivar's concept that we need to revisit. So what I had LSO draft, the first amendment that you see goes through all the places where they put in the sunset date. You'll see just page 1, line 7 about providing a sunset date, then this little sunset bit there on the bottom of the page and the top of the page. And then it goes through these various places where they inserted in Title 25 and throughout that these changes that we made to the definition, or to have substance abuse rather than substance use or whatever, will all sunset. I mean, we're taking that back out because they put them in really sprinkled all throughout the place. And that's it. All it is. So all this, it's very lengthy doing, but all it is doing is backing out that sunset part. So, and it's one amendment, but then linked with it, obviously conceptually, and we would certainly want to do both of them, I would think. I mean, you wouldn't have to do the second part, but what I did on page 25 then, so we have on page 24, line 16, we have asked the department to report to us before July 31st, kind of on where they're at and going on. So in lieu of a sunset date, what I have brought is the purpose of the sunset date was on the amendment. On or before September 1, 2025, department shall report to us, provide an update, include any recommendations for modifying the priority population. So in other words, by putting in the statute that they have got to come back, they will have to be back, they will have to present on prioritization. The Labor Committee will have to consider it again. Do we want to tweak it without the danger, what I think is a danger of having a sunset date in there that could somehow be missed. I mean, you just never know what happens when you put in a sunset date. So that's Representative Stiver. That is what I have tried to do to get at what you're doing, which is make sure we have oversight without kind of having an accident happen. Representative Stiver, I'm going to call on you. You didn't put your hand up, but because it was your original amendment, I want to give you a chance to talk.
I agree with this, and I'll second your amendment.
Awesome. Thank you very much. Okay. Well, so I guess I didn't really move them technically, but I moved the first amendment. I don't see, it doesn't seem to have a number. The repealer, we'll have to take them in part in one and then the other, I guess, because they're typed up that way. But Representative Connolly.
Thank you, Madam Chair. And I must admit, I am thrilled about the amendment that deletes the repealers on the first page. Admittedly, when we first took a look at this bill, and I was preparing with my green books, I was panicked about honestly what this bill was doing on the first page, because it was getting rid of all of community mental health. And so I appreciated, honestly, our last meeting, learning that honestly would be taken care of.
Right. That was kind of an accident.
Yeah. So I'm very glad, and the reporting as well. However, that being said, and I will vote for the amendment, that's for sure, but it did bring up to me the recognition that it being crucial that the committee reevaluate what's going on, to me was an indication of a big red flag, that this is such an incredible change. And considering if there was an alternative that might be better, and that the alternative that came to my mind would be a pilot program, rather than making the entire state do this immediately and have us come back in 3 years and maybe say, oops, that maybe there's a better road. And so just my comment that I will vote for this, but it also made me think that there could be an alternative to what we see before us. So thank you, Madam Chair.
Certainly, as chairman of labor for this interim and the next, I mean, after that, unless I'm hit by a bus, I certainly commit to putting this type of issue as far as community mental health services on our interim topic every summer. I think that's that's something that we have really tried to work on. It needs more work. It'll get better work when we're not in little rectangles on a screen. And I certainly, I don't disagree in any way. Any more discussion of the first deletion amendment? Okay, then all in favor of my amendment number 1 with the deletion of the sunset date of the whole page, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, 9-4, thank you. And none against. That amendment passes. And then the second amendment I presented already. It's really a companion amendment, and that is the reporting date, or the 2025 report, to make sure that we maintain the oversight. Any other discussion on that one? And Representative Stiver, were you seconding in a group? Okay. Group second, okay. Okay, no other discussion then. All in favor of the second amendment with the reporting requirement, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9-0. What a happy committee. I'm so happy. Okay, that amendment passes. All right, so far we have 3 amendments. I'm bringing this forward. A person might want to make this. I'm just discussing it on page 24, line 16, where we have the report, July 31st. We may or may, I mean, we'll have one meeting normally before July 31st. I mean, I don't know what, we may have another special session this summer. I've heard some rumblings about that, depending on what the feds do. I don't even know, but I'm sure we can get in one meeting. Whether we want to maybe put that to be August 31st or September 30th to maybe give a little bit more time. I'm really flexible on that, so I'm not going to make an amendment unless somebody else wants to. Representative Worf.
Madam Chairman, I would make that recommendation. I think it's too quick. This is a rather substantial change that we're putting forward. And I mean, I still have some uncomfort in it. There's enough questions, and being new on the committee, I don't want to stop it, but I just don't think that July of this year is going to give them enough time to really be able to determine whether we're achieving what our goals and objectives are. So I would think it's better to push it back. I hate to push it back into hunting season because that's September and October, but Madam Chairman, I will, I guess, make that motion if you think September or October would be the better time. I just think we need to give them more time to fully be able to assess whether these changes are working, identify where the problems are so that we can fix them. And I would even push it back to November. I mean, I don't know. I guess I'm kind of torn. All three of those months impact my hunting. So September would probably be the better for me, but you know better
Pick a
that.
date, Representative Wharf, and we'll follow on from there. You
Let's go
want
with September 1st.
September 1st.
September 1st. Okay. You know, that leaves you bow season, but you know, all I really care about, Representative Wharf, is antelope season in my hunt area opens September 25th. Other than that, the heck with the rest of you. So is there a second for an amendment on page 24, line 16, deleting July 31st and inserting September 1? Do we have a second? Seconded by Romero Martinez. Any discussion? No discussion. All right, all in favor of that amendment, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. And all opposed? 1. Okay. All right, that passes. Okay, any other amendments or discussion?
Madam Chairman, can you hear me now?
I can hear you, Bonnie.
Great.
So Bonnie, we have, just to clarify, so far, and are there going to be any other amendments? I just want to wrap up with Bonnie. Okay, I don't see it. So Bonnie, what we have is the amendment on page 16, line 5, changing abuse to use. We have the two amendments that were circulated, one with the deleting the sunset and then the other changing the reporting date. And then we have on page 24, line 16, changing July 31st to September 1. Did I miss anything, committee? Okay. All right, then.
Madam Chairman, were there any amendments to your two amendments that you submitted to me this morning?
There were not.
Thank you.
Lucky, huh?
Yes.
All right. Very good. Sounds like, oh, Representative Hallinan. You're muted.
I call the question.
I was just about to do that. Very good. And we'll even be done before lunch. It's a novelty. Surely we can do something else. Where am I at? Bonnie, call the roll, please.
Representatives Clifford,
Clifford, no.
Connolly,
No.
Flitner,
Aye.
was that an aye?
Littner, aye. My apologies.
Hallinan,
Aye.
Ottman,
Aye.
Martinez,
Aye.
Stivar,
No.
Wharf,
Representative Wharf votes aye.
Madam Chairwoman,
Aye.
Madam Chairman, we have 6 ayes, 3 noes.
Very good. And I will consult committee to see how we want to run this on the floor. I mean, it's possible I may involve Representative Larson as chairman of Representative Stivar. I'll find something. I think we'll let you run Medicaid expansion. Okay, committee, that's all we have. Monday morning, bright and early, unless I hear further. Let me just check my inbox well here to see if I saw some horrible shocked look. Just a minute. Okay, I haven't had any response from them. So unless I hear otherwise before Friday, we will consider those two bills, House Bill 83 and House Bill 111, Monday morning at 8, not 8:30, 8. And remember, we'll need to be concise now because we'll be have to be due in the chamber at 10. We'll be in room 3 in the Hirschler connector. You can see Bonnie there having our wonderful room all set up, and we've got a seating chart. I'll just let you know as far as the seating chart. I have kind of set it up to distribute new members and previous members, freshmen and not freshmen, and kind of distribute them around that way, just so that you can lean to your neighbor masked or however, don't breathe on them, but so that we can all do well in our new committee space. Okay, anything else for the good of the order before we adjourn?
Madam Chairman, I had one question.
Bonnie.
System went down. We were on page 25, changing line 20, July 1st, 2022 to July 1st, 2024. Did that pass?
Representative Stivar withdrew that.
Withdrew. Thank you.
Okay. All right, folks, have a good next 2 days and weekend. Strengthen up, get lots of protein and whatnot for the session. And I really look forward to seeing everybody in Cheyenne. So I haven't decided yet. I was thinking maybe I'll try to have a little get together at my house Sunday night. I have to think about that. I haven't quite decided, but it would be sure nice to just chat a little bit before we launch into our firefight, so to speak. All right, meeting is adjourned. Thanks very much.